The Washington Manual of Surgery podcast is based on the 9th edition of the best-selling Washington Manual of Surgery.
This podcast is meant to condense key topics from our manual into bite-sized episodes for your convenience. Now, on to this installment of the Washington Manual of Surgery podcast.
Well, hello, everyone, and welcome to the Washington Manual of Surgery podcast. We bring you everything you need to know about high-yield general surgery topics built for your just-in-time learning. On this episode, we're thrilled to have Dr. Michael Brunt here to review the management of all things adrenal. Dr. Brunt is the Pruett Professor of Surgery here at Washington University in St. Louis. He's been a high-volume adrenal surgeon over the course of his long career. My name is Corbin Frye. I'm a general surgery chief resident going in endocrine surgery, and I'll be the host today for this podcast episode.
Thank you very much, Corbin. It's a pleasure to be with you today and to talk about one of my favorite topics, adrenal tumors and adrenal surgery.
Today, we're going to be talking primarily about adrenal nodules and the various endocrinopathies with which they can be associated. Specifically, we want to talk about this in the context of adrenal incidentalomas. They're surprisingly common, can occur in up to 5% of all CT scans and even up to 10% in some certain patient populations. So let's dive right in for a case, Dr. Brunt. So we have a 55-year-old female. We're seeing her in the clinic. She was recently in a low-speed MVC, was seen in the ER, had a CT scan about a month ago that found a small adrenal nodule. Otherwise pretty healthy, has some hypertension, has never had surgery, pretty unremarkable family history. So Dr. Brunt, just talk to us a little bit about what you're thinking about when you're seeing this patient for the first time, your history, your physical, your workup, and any differential diagnosis that you're thinking about.
So adrenal incidentaloma is the most common adrenal abnormality that surgeons and actually clinicians are asked to see because they're so common and because cross-sectional imaging of the abdomen is ubiquitous. When you have somebody who has an adrenal incidentalloma, there are two essential questions to ask. The first is this functional or hypersecretory or not? And then the second is this malignant or could it be potentially malignant? Because if the answer to either of those questions is yes, then it should come out. And if the answer is no, then it's probably something that can be followed or maybe even dismissed after appropriate evaluation and assessment. So when I'm looking at these patients, there are a number of things that you want to do. Of course, history and physical examination, particularly in regard to hypertension or any other changes with the patient. Most patients, hypertension is very common, but most patients won't have other significant things in their presentation that would make you think immediately that this is a hypersecretory adrenal lesion, because otherwise they would have been picked up, and it's not truly an incidentalloma. So you want to assess for that, and the best way to do it is with biochemical testing. It's actually very straightforward. There are three conditions that you want to test for. If the patient is hypertensive or hypokalemic, then they should be screened for primary hyperaldosteronism. That is easy to test with an upright plasma aldosterone and renin level. And if that's normal, then you can eliminate it. The second condition to test for is for hypercortisolism. And there are patients who have mild autonomous cortisol secretion without obvious Cushing's features. And so the easy way to screen for that is with an overnight dexamethasone test. And what we do in our practice is we give the patient a prescription for dexamethasone 1 milligram. They're instructed to take it at 11 o'clock at night, and then they get an 8 a.m. plasma cortisol. They can do that at their local lab facility or hospital, so they don't have to have it done in your institution. And normal patients should suppress to less than 1.6 micrograms per deciliter. There'll be some patients who incompletely suppress, and then that might require further testing. We do get dexamethasone levels also to ensure that they took the dexamethasone. And then the third component of screening is to rule out a pheochromocytoma. And that's important because actually 30 to 40% of pheos today present as incidentalomas. And the easy way to screen for that is with plasma fractionated metanephrines. And if those are normal, then you've ruled that out. So that's the initial screening that takes place. The other second consideration is the imaging appearance. And so the most common lesion that presents as an incidentalloma is a cortical adenoma. These are usually non-functioning. There are certain characteristics for that we may get into later. And so the imaging appearance, both the size, homogeneity of it, whether there's intracellular lipid or not, the attenuation values on the lesion, and other factors are determined whether you can essentially call this an adenoma right off the get-go, or if you need additional imaging or other testing.
Yeah, that's really helpful. So let's dive in just a little bit to some of the details on the imaging. People talk about an adrenal protocol scan, and just for everyone, there's typically 3 phases when we talk about that adrenal protocol CT scan. There's a non-con phase, a portal venous phase, which is at about 1 minute after contrast, and then a delayed phase of 15 minutes. How do you think about each of those phases? I know there's something about 10 Hounsfield units, and being less than that is helpful for telling you that it might be benign. And then we also look at washout occasionally. Can you talk to us a little bit about some of those details?
Well, so I think the important principle to think about is that adrenal adenomas have a lot of intracellular lipid, and so they're going to be lower in attenuation on CT scan imaging. Most of the patients who come with an incidentaloma, a lot of them have had IV contrast. If I'm just evaluating the adrenals per se, I prefer to do a non-contrast CT scan, because then you can assess the attenuation. And there are various, washout figures that you can look at as well. And Corbin, I think you may want to comment on that a little bit further. And so that's the initial assessment.
That makes a lot of sense. And yeah, so the guidelines would state that on the non-con scan, if you have a Hounsfield unit, which is just an indicator of how dark the lesion looks, so a dark hypoattenuating lesion that's less than 10 Hounsfield units, you actually don't even need to get any further contrast imaging. Is what the guidelines say. We feel very confident it's a benign lipid-rich adenoma. As far as the contrast phases go, the way that I remember this is that cancer likes to hold on to contrast. There's a large capillary bed. The cancers really hold on to the contrast. And so that's how I remember that. We're looking for low washout characteristics. That would be less than 60% for an absolute washout, or less than 40% for a relative washout. Those would be concerning for malignancy. And so those are the numbers that we're looking about. So very good. All right. Well, let's that's a great intro and discussion into the adrenal incidentalomas. So let's talk about some of the specific endocrinopathies and specific differential diagnoses that happen. So let's start with a non-functional tumor, kind of your run-of-the-mill. It's a tumor. Your biochemical analysis has been negative. Your imaging workup is negative for any type of malignancy. How do you manage these? How do you follow these, Dr. Brunt? What do you recommend for your patients?
Well, I think the guidelines have changed a bit on this. Typically, after you do the initial screening, then the recommendations were, to have a follow-up scan in 6 to 12 months, and then maybe at 2 years. But if this is a small lesion, 2 to 3 centimeters, looks like an adenoma, all the biochemical testing is negative, they probably don't need any further follow-up or assessment of it. And so those are the newer guideline recommendations that have come out. I think you base it on the patient, on the imaging characteristics to a large extent. And if it's in that 3 to 4 centimeter range, then I probably would see that patient back and get follow-up imaging assessment at a year, and then you can consider whether you would do any repeat biochemical testing or not. The chances that a non-functioning lesion will evolve and progress to one that is secreting excessive cortisol is very low. It does happen, but it's a very low instance of that, and it can take a few years for that to take place. So I think we've moved towards a position of less follow-up imaging rather than doing it on an every 1 to 2 year basis. Now, that's for a perfectly benign looking classic adenoma small lesion. For lesions that are indeterminate, that's a different story.
Yeah. And you make a great point. There's really not a ton of great evidence-based guidelines when it comes to following these. It's really kind of dealer's choice and a lot of surgeon and provider preference. There were some recent AAES guidelines that came out in 2022. They say that you should resect anything that's growing over a centimeter in a 12-month period. So typically for most larger tumors, as you stated, they'll get a follow-up image at around the 12-month mark. But some of those smaller tumors, especially if they're less than 10 Hounsfield units, you really don't need any follow-up at all. In regards to biochemical evaluation, the AES simply says to consider cortisol testing at a 2 to 5 year interval. So you can see there's a lot of wiggle room in there. And they just state that, cortisol is the most common hormone to develop excess during surveillance. And so that's really helpful. So let's get right into that. It's a good intro into cortisol excess. This is the most common type of hormone excess. Somewhere between 5 to 10% of incidental adrenal lesions have hypercortisolism. This can go all the way up to 30 to 35% if you include MAX, which is mild autonomous cortisol secretion. So before we get into, Dr. Brunt, your kind of recommendations and how you manage these patients, let me just clarify a couple things, terminology. I know this used to confuse me. So let's just go through these briefly. Hypercortisolemia or hypercortisolism, that's just the state, a biochemical diagnosis. That's the state of inappropriately high cortisol. As opposed to Cushing's syndrome, this is actually a clinical diagnosis. This is both the biochemical hypercortisolism, but also the signs and symptoms that are related to Cushing's syndrome that we'll probably get into. We remember studying these from step 1 and for the ABSI. These include central obesity, buffalo hump, moon facies, striae, fatigue, muscle weakness, all of these types of things. And then we hear about Cushing's disease. This is a specific type of Cushing's syndrome. This is a commonly confused terminology point here. Cushing's disease is Cushing's syndrome with the etiology that comes from an ACTH-producing pituitary gland. And so that's specific when we use that term disease. And then lastly, we just talked about MAX, the mild autonomous cortisol secretion. It's essentially subclinical hypercortisolism. They have hypercortisolism on their biochemical evaluation, but they don't have the classic stigmata of Cushing. So with a lot of those kind of technical details out of the way, tell us a little bit about kind of your workup for Cushing's and kind of how you're managing these types of patients.
Yeah, so if you have somebody you suspect that diagnosis in, or if the dexamethasone test doesn't suppress, then the next step is usually to get a 24-hour urine-free cortisol and or salivary midnight cortisols. Random cortisol levels don't really help you and are to be discouraged. And if those are abnormal, then you've essentially established that the patient has hypercortisolism. And the next step is to differentiate ACTH dependent from independent sources, i.e. Pituitary or ectopic ACTH, which we see very infrequently, from an adrenal-based. And the easy way to do that is to get a plasma ACTH. And if it's suppressed, then that indicates that it's likely an adrenal source. And then the third step would be to get cross-sectional imaging to evaluate that. Now, the incidentalomas, they come to us already with the imaging, and that's the reality a lot of times. But if you're seeing somebody de novo with a suspected diagnosis, those are the steps that you should go through.
Makes a lot of sense. And I know, classically we've always treated Cushing's syndrome with adrenalectomy, but what about MAX? I know previously a lot of people weren't recommending surgery for that. I know in the last, maybe decade or so that's been changing. Tell us just a little bit about your management of that mild autonomous cortisol secretion.
Yeah, so I mean, this is really something that's higher level endocrine practice. And we're seeing a few more of these patients. And I'll just say previously, you'll hear the other term that you'll hear is subclinical hypercortisolism or subclinical Cushing's. And these are patients that have these biochemical abnormalities, but not all the classic florid features of Cushing's, although they may have a little bit higher incidence of diabetes or obesity or hypertension. There have been some studies that have looked at following these over the years and shown that some of these patients go on to progress, but it's a relatively low incidence, and some of them do better in terms of longer-term control of their hypertension, diabetes, et cetera. So I think it's shared decision-making with the endocrinologist because they should be involved in these mild cases, and also with the patient and what their goals and expectations are. And it's a little harder to predict in these situations how much benefit clinically the patient will actually get. And typically, if they're having this to a significant degree, they're probably going to have an adenoma that's 3 centimeters at least, or a little better. The really small ones, 1.5, 2 centimeters, don't usually do this. And the other part of the conversation to have with the patient is they may require a period of exogenous glucocorticoid administration afterwards that can last for 2 to 3 months. And what we usually do is test the patient the morning after surgery with an AM cortisol, and if it's low, or then they get replacement. If it's intermediate, they'll get an ACTH stimulation test. If it's normal, then we don't give them anything because you don't know for sure how they're going to respond to the adrenalectomy and to what extent this has actually suppressed their pituitary adrenal axis.
Yeah, makes a lot of sense. That's great. So let's move on to the next endocrinopathy. So let's talk about hyperaldosteronism. When hyperaldosteronism is caused by an adrenal adenoma, we call this Conn syndrome. It's found about 1 to 4% of the time with new adrenal incidentalomas. So what kind of patients are you thinking about, when it comes to your history and physical, and then how do you manage these types of patients, Dr. Brunt?
Well, it's interesting because primary hyperaldosteronism is the most common hypersecretory adrenal lesion. And it's important to recognize that there are 2 main subtypes. There's aldosteronoma, which is a solitary aldosterone-producing adenoma, and then there's idiopathic hyperaldosteronism from cortical hyperplasia. And it's important to differentiate because we take aldosteronomas out and we don't take out both adrenals when somebody has hyperplasia. These patients typically present with hypertension that is refractory to usual medical management, and they may come in on 4 or 5 different antihypertensives. I've seen patients who've struggled with their hypertension for years before somebody thinks of the diagnosis. And any patient who has hypertension, young age of onset, difficult to control, or hypertension and hypokalemia, you should always screen for this diagnosis. These don't often present as incidentalomas because they're small. They're 1 to 2 centimeters, and most of them don't get referred for further evaluation. But this is common in the population. It's been looked at across multiple continents. 8 to 12% of hypertensive population may have primary hyperaldosteronism. So it's important to screen for it. It's easy to do with aldosterone and renin, and then it's a matter of determining whether they have a lateralizing, that is unilateral source of increased aldosterone production or not. You can get a sense for that with cross-sectional imaging, but you can also be misled by that. So the gold standard is adrenal vein sampling from both adrenal veins in the inferior vena cava, measuring both aldosterone and cortisol levels, and you look at the ratios. And if you have a unilateral source of increased aldosterone production, then you will have a gradient of aldosterone to cortisol ratio gradient between the two sides of 4-fold or higher. So it's important to do that. We don't do it in everybody, but the vast majority. A younger patient under 45, solitary macroadenoma that is greater than 1 centimeter and a normal contralateral gland, will oftentimes just take it out. And everybody else gets vein sampling because as you get older, the incidence of small nodules increases. And so different endocrine surgeons approach this differently. Some are less aggressive about doing vein sampling. Some do vein sampling in everybody. We do it in the vast majority, but that's the gold standard test.
We hope you enjoyed this installment of the Washington Manual of Surgery podcast. Stay tuned for part 2 of this episode to learn more about adrenal cancers and adrenalectomy. We are Drs. Paul Wise
and Jeff Blatnick,
senior editors of the Washington Manual of Surgery. We'd like to thank the residents and faculty of the Department of Surgery at Washington University Medicine, and we'd especially like to thank our associate editors for this edition, Drs. Catherine Caldwell, Ina Chen, Bradley Kushner, Martha Bucky McGilvray, and Jorge Zarate Rodriguez.
We hope that you enjoyed this episode of the Washington Manual of Surgery podcast. For more comprehensive information in a brief outline format, check out the print and digital version of the Washington Manual of Surgery, published by Wolters Kluwer Health and Lippincott Williams & Wilkins. Please search online for the Washington Manual of Surgery 9th edition to purchase your copy of the manual.
To learn more about the educational opportunities available in the Department of Surgery, please search General Surgery Residency at Washington University School of Medicine in St. Louis.